Good afternoon, everyone, and welcome to Measuring What Matters, Improving Patient Outcomes Through Lipid Monitoring and Management. I'm Rebecca Licky. I'm the National Director of Quality Programs at the American Heart Association, and I'm so excited to be helping to host today's event. Quickly jumping in to provide just some general disclaimers for today, noting that the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the Heart Association. The American Heart Association does not endorse any product or service. All right, moving again quickly into some housekeeping items. Please note that today's webinar is recorded and will be shared following the event to all registrants. Closed captions are available via the CC icon at the bottom of your screen, and resources such as the slides for today's presentation are found at the resources icon, again at the bottom of your screen. We will have lots of time for questions at the end of the presentation. So as we are going along, please use the Q&A panel and we will address as many questions as possible in the last 15 or so minutes of our session here together. So we've got a very exciting agenda here for today's webinar. We'll start with just brief intros of our speakers and move right into understanding quality measures and the merit-based incentive payment system, or MIPS. We'll talk through a new LDL-C monitoring and management measure coupled with some implementation strategies. And then again, we'll end our 45-minute session with a Q&A. All righty. Well, I am very honored to introduce you to our presenters for today. First up, we have Sarah Gearhart, Program Manager for Health Science at the American Heart Association, as our expert for quality measure development. Sarah currently supports measure development for the Outpace CVD and Get With the Guidelines stroke programs. And prior to joining the association, worked on federal inpatient and outpatient digital quality measurement products for the Centers for Medicare and Medicaid Services. Joining her today, we have an exceptional volunteer, Dr. Nishant Shah, cardiologist at Duke University Medical Center and faculty of the Duke Clinical Research Institute. Dr. Shah is an expert in preventive cardiology with research expertise in clinical manifestations of genetic lipid biomarkers, lipoprotein A, and advanced dyslipidemias. He is also a very active volunteer with the Heart Association for implementation science initiatives at both the primary and secondary prevention level. So with that, I am excited to pass it off to you, Sarah, to get us started. The floor is yours.
All right. Thank you, Rebecca. All right. I'd like to begin with an overview of quality measures. If we could jump into the next slide, please. Thank you. So at their core, clinical quality measures create a framework for recognizing and rewarding high quality care. First, we translate evidence-based clinical guidelines into measurable actions. These measures help guide care and improve patient outcomes over time. We can then use these clinical quality measures to recognize and reward adherence to evidence-based care. Next slide. Thank you. So there are a few important considerations that I'd like to call out here. First, quality measures are designed to drive improvement, not require perfection. The goal is not to capture every possible clinical scenario or to replace the judgments of our clinicians. Measures should always be applied in the context of individual patient needs. Not all exceptions or exclusions are specified, and this is by design. In some cases, they are intentionally not included in order to encourage patient education. Again, the goal of quality measures is improvement. Next slide. Now let's review a basic performance calculation for a proportion measure. Proportion measures calculate a comparison of patients who received quality care to the total number of eligible patients. For example, we would compare the number of patients who received a lipid panel to the number of patients who should receive one. Now let's walk through the population criteria that make up a proportion measure. So first, we have the initial patient population, or IPP. This is the total scope of patients for whom the quality action is appropriate. From this population, we derive the denominator. This may be equal to the initial patient population or it may restrict the population further. For example, the IPP may be all adult patients with a diagnosis of stroke, where the denominator would look at patients who had a specific procedure or intervention. Next, we have denominator exclusions. These are the patients who are always removed because the quality action is not appropriate. This frequently includes patients in hospice care or with advanced illness or frailty who may not benefit from these interventions. The numerator is the group of patients who receive the quality action of interest. And then finally, we have denominator exceptions, which are evaluated last. These are the patients who are removed from the measure only in the event that they do not meet the numerator. For example, denominator exceptions account for situations in which a patient would otherwise rightly be included in a measure population, but has a clinical contraindication, such as an allergy, that makes the recommended care inappropriate. Denominator exceptions only help improve performance rates. All right. So here we're going to go through the anatomy of a measure with the same population criteria we just reviewed. So the purpose of this visual will be to show how each population criteria contributes to the performance rate. The IPP is, again, the target population for the measure set. Angela, if you'd like to, thank you. From the IPP, we pull the denominator population, which is a subset of the original population, who should receive the quality action that is the focus of the measure. As I noted before, sometimes the denominator is the same as the IPP. Denominator exclusions apply to patients who would otherwise qualify for the measure, but have clinical circumstances that make the quality action inappropriate. These patients are removed from the denominator entirely. Next, thank you. And then next, the numerator represents the subset of denominator eligible patients who receive the required care or achieve the desired outcome. Denominator exceptions are only evaluated when a patient does not meet that numerator, and there is a documented reason why the quality action was not completed. In those cases, the patient is removed from the denominator and is not counted against performance. In order to calculate the performance rate on the right side of the screen, we divide the numerator by the denominator minus denominator exceptions and exclusions. Next slide, please. So to provide a concrete example of these population criteria, let's go ahead and review a theoretical measure that looks at blood pressure control. For this measure, the IPP is all patients ages 18 to 85 through the end of the measurement period who have a diagnosis of essential hypertension during the measurement period or the prior year. So in our example, the denominator is the same as the initial population. Exclusions for this measure are patients who are in hospice care, who are pregnant, and or patients 66 years of age or older with advanced illness and frailty. These patients have unique circumstances when it comes to blood pressure control and should not be included in the measure. The numerator is the population of patients whose blood pressure was adequately controlled at the 140/90 millimeters of mercury threshold. So in the illustration, the patients in black are in the numerator, while the patients in red failed the numerator due to not having adequately controlled blood pressure. There are no denominator exceptions. The performance rate in our theoretical patient population is 57%, since 4 of 7 eligible patients had their blood pressure controlled. So now that we've covered the basics of quality measurement and population criteria, I do want to provide just a brief overview of measure development at the American Heart Association. So we begin with a new proposal for a measure, which may originate from a new guideline, a measure from the Joint Committee on Performance Measures, or an identified research need. We then conduct an environmental scan or a basic process of information gathering. Next, we collaborate with the appropriate subject matter experts, which includes clinicians, to draft a concept. Module leadership, such as the Systems of Care Advisory Group, approves the concept, and then we collaborate with our health information technology colleagues to implement and launch the measure. Sometimes this requires creating new data elements. Before the measure goes live, we conduct testing to confirm that it's operating as intended in the registry. Feedback on testing can help us to refine the measure as needed. And then finally, we release the measure and iterate based on feedback and future guideline updates. All right, now that we've covered the basics of quality measures and how the calculation works with population criteria and our process for measure development at the association, I do want to provide a brief overview of the Centers for Medicare and Medicaid Services Merit-Based Incentive Payment System, or MIPS, and how development at the association could feed into future reporting opportunities. So what is MIPS? MIPS is one of two tracks under the Quality Payment Program, or QPP, which was implemented in 2017 by CMS. QPP was established by CMS to reward clinicians with payment increases based on their performance on four components: quality, cost, improvement, and promoting interoperability. If an individual fails to meet QPP benchmarks, they may be subject to a negative payment adjustment. For the purposes of today's call, we're going to focus on quality. So what are the MIPS quality requirements? MIPS offers two options for participation: traditional MIPS and MIPS value pathways, or MVPs. Both pathways use quality measures to assess healthcare processes, outcomes, and patient experiences. Clinicians and practices must collect and submit data under both pathways for the 12-month performance period from January 1st through December 31st. During this period, they must report performance for at least 75% of cases that are eligible for the denominator. Now for the differences between traditional MIPS and MVPs. So under traditional MIPS in 2026, clinicians and practices are required to report 6 quality measures. These can be selected by the clinician or the practice. At least one of these measures needs to be an outcome measure or a high priority measure. MVPs are designed to be aligned with clinical themes. In theory, MVPs will allow for more apples to apples comparison among specialists on quality measure performance. In 2026, measures for MVPs were pre-selected, such as for cancer care or heart disease. How does payment incentivization work? Performance on quality measures, along with performance on the other 3 categories, contributes to an overall performance score. Higher scores may lead to bonus payments and positive adjustments, while lower scores yield penalties in future payment years. Overall, this program is designed to incentivize high-value care. So now let's take a closer look at the LDL-C monitoring and management measure. So the American Heart Association developed this measure to address an important gap in cardiovascular quality measurement and provide clinicians with a meaningful way to demonstrate performance in lipid management. The LDL-C monitoring and management measure is currently under consideration for inclusion in MIPS performance year 2027 as an intermediate outcome high priority measure. If this measure is finalized under notice and comment rulemaking, clinicians will be able to report progress on this measure as part of their quality component in traditional MIPS and potentially MIPS value pathways in a future reporting year. So here's a timeline of this process. At a high level, the important thing to note is that measures finalized this year will impact payment adjustments in 2029. If we assume that the LDL-C measure is finalized through notice and comment rulemaking in November, data collection would begin January 1st, 2027. Then clinicians would submit all data the spring of 2028. These data and performance would ultimately impact payment adjustments in 2029. Again, this is pending finalization through notice and comment rulemaking. And just as an aside, I'd also like to note that this measure will be updated for inclusion in the Outpaced CVD registry at the association. And contact information for those of you who would like to learn more about the Outpaced CVD registry will be listed at the end of the presentation. All right, I'll now pass the presentation to Dr. Shah, who will review the measure construct and the clinical rationale.
Well, thank you so much. I really appreciate it, Sarah, for setting us up. I think the context of how these quality measures are developed is very important. And like to say, too, it's just been an absolute honor to work with the association and several other volunteers in helping craft and promote this measure. So I think for those that don't know me, and I am a preventive cardiologist, and so this is what keeps me up at night is that there's so many people out there that have uncontrolled LDL, a very modifiable risk factor, just like hypertension, just like diabetes, but they don't know that it's elevated. And we have an opportunity now, not only at our individual systems or individual patient panels, but hopefully now nationally, if this measure moves forward. And so I think it's a nice step forward from a public health standpoint, knowing that cardiovascular disease remains the number one killer across the world. We can go to the next slide. And so I just want to comment on some clinical rationale around the measure. And so, when this measure was being crafted, if you will, we at the time we only had the 2018 cholesterol guidelines to go by. And I think many on this call know, if not everybody on this call, and that the number 70 was a really important one, especially for patients with clinical ASCVD. There's a plethora of data showing that the lower you go, the better it is. And so with that, in the 2018 guidelines, we marked 70 as somebody that with clinical ASCVD to target. Okay. But you're not going to know if somebody is at under 70 or not unless you actually check a lipid panel. And so a couple of points I just want to point out is that there are two class 1 indications, at least in the 2018 guidelines, which are also now in the 2026 guidelines, to ensure that patients of all kinds are getting lipid panels, especially patients with clinical ASCVD. It's a class 1 recommendation to get a lipid panel drawn. And in addition to those with ASD in the prior iteration of the guidelines to hit an LDL of under 70 milligrams per deciliter, the lower we go, the better. There was also some guidance in terms of the proportion of reduction, with at least 50% reduction in baseline LDL being a number that was thrown out in the guidelines with a class 1 recommendation. So, many of us in the world of preventive cardiology really focus on, under 70, 50% lower than baseline, the lower the better, right? Whichever one is lower, right? So, but sometimes that 50% becomes very difficult to measure, right? When you have people was pre-statin, on statin, or non-statin, et cetera, et cetera. And so the number 70, just in general, was a little bit to follow. We can go to the next slide. And even when you look at guidelines, across the board, so this is a chronic coronary disease management guidelines, high intensity statin therapy in patients with clinical ASCVD is recommended, but they also make note of that 50 deciliter in clinical to the development of the measure. Next slide. And so, before I get into, what we defined our measure, it's really reassuring that the guidelines that came out after the measure was developed, the 2026, the most recent guidelines, promote going even lower in those that are at very high risk ASCVD, right? So we all know the number 55 now, which is very important. People who meet the criteria for very high risk ASCVD. So someone who's had 2 clinical ASCVD events, or at least one a clinical ASCVD event, plus at least 2 high risk factors. And so that is now a class 1 recommendation in the 2026 guideline, all consistent with we need to be under 70, and in some people we need to go even lower. Next slide. And so this is the overview of the measure that was put forward by the AHA, which is defined as how it's listed here: a percentage of patients aged 18 years and older with clinical atherosclerotic cardiovascular disease, or ASCVD, who received a low-density lipoprotein cholesterol test via lipid panel and achieved an LDL-C less than 70 milligrams per deciliter on their most recent test during the performance period. This is very crucial, this two-prong approach here, because how are you going to know if somebody's under 70 if you don't test? And if you look at the data across the country, in addition to having an issue of getting patients with ASCVD to LDL goal, we also have a really big issue in this country about actually testing lipid panels. You can look at the data, even patients after clinical ASCVD events, the number of times they get fall LDL after initiation of, let's say, a therapy while they're admitted is very low. And more data is coming out. The faster we get people to goal, the better it is in terms of overall risk reduction. So the rationale here is the most evidence-based rationale at the time with the current guidelines when creating the metrics to help improve overall cardiovascular risk in terms of LDL reduction. Next slide. So this is just for illustrative purposes, but how is CMS going to look at this, right? How is someone who's measuring the performance going to look at this? So looking at it, as I mentioned, in a two-pronged way. So it's going to be patients who are diagnosed with clinical ASCVD and have an LDL-C test. That's very important. So that's what you see on the pie graph on the right. Again, this is illustrative purposes only, just to show, okay, all right, look, we're seeing we have a population, as Sarah very nicely defined. You're defining your denominator, right? And then of those folks, how many of the people actually had an LDL-C test? In this perfect, almost perfect world, 98% of people have a test. Great. But then there's another level to it. All right. So now you're getting to patients with clinical ASCVD who had an LDL-C test and have an LDL-C less than 70 milligrams per deciliter. So you can see here just example of what that would look like. How you might see a bigger split potentially, right? 56% versus 44. And so the idea here is that the measure is going to be looking at both of these things together to give sort of an overall performance rating. Next slide. Again, looking at the submission criteria one, patients diagnosed with clinical ASCVD and a lipid panel. All right, we kind of list out here some of the denominator exclusions. Of course, I think things like there's a positive data here, right? Pregnancy, a lot of therapies have not been studied in clinical trials in pregnant patients, right? So they are excluded from the denominator. Patients on hospice excluded from the denominator. Patients with end-stage renal disease have been excluded from the denominator. Again, there is no data, and we need more data because these are also high-risk patients in these groups. But until there's more data, very difficult to include them in performance measures. Those that have advanced illness, very frail, where life expectancy are limited, right? Those are excluded. So you're really looking at patients who are relatively functional, have a lot of life to live, if you will, and don't have any other comorbidities or other medical diagnoses or other conditions that would prevent them from being on a lipid-lowering therapy. So we're trying to enrich this population that would be measured or followed to a group that actually would benefit from aggressive lipid lowering therapy, right? And then numerator, of course, the patients with ASCVD who had an LDL-C test via lipid panel. So that's kind of breaking down what that first part of the measure is. And next slide, we'll go into the next part. And so the next part here is patients diagnosed with clinical ASCVD with a lipid panel, but also with an LDL-C under 70. Okay. So again, very similar denominator exclusions. And then there's some denominator exceptions as well that I just want to point out. Documentation, for instance, of a medical reason for not managing lipids, right? Drug-drug interactions, intolerances, of course, allergies, et cetera, right? Because those are all very important to consider, when somebody has clinical ASCVD but just aren't at goal. Is it fair to include some of those exceptions? So hence they've now been officially accepted or as an exception to make sure that we are following the right patient population so that people are being measured based on the right patient population. Okay. All right, next slide. And so this is an example of what CMS would see again in terms of giving an overall performance rating. So looking at both criterias, and you can see how together you will determine an overall performance. And so you have the first component, which is testing in patients with clinical ASCVD. Second component, those with clinical ASCVD who are tested in LDL less than 70. And pretty much putting it together, you will get a performance rating, in this particular case, about 77%, based on criteria one's performance and criteria two's performance. They go hand in hand. Next slide. So now the question really becomes, all right, if this measure moves forward and it is selected as something to follow at the system level, how do we actually hit that metric? How do we hit the ball out of the ballpark? How do we really do well in making sure not only people with ASCVD are tested, but those that are tested also get their LDL under 70%, right? Or 70 milligrams per deciliter. So how do we do that? if there was like an answer that like fixed it all, I would totally tell you right now, and like it would be very well known, and we wouldn't even need this measure, right? But this is still being iterated. This is still being studied. As someone who also does a lot of implementation research, um, this there's no perfect answer on how to make this work. And what we are learning is that every system, every practice, every provider, every patient has different strategies that work well for them and strategies that don't work well for them. So it really comes back down to institutional culture, institutional specific gaps, institutional specific barriers and hurdles to really get to the overall goal, which is just controlling people's LDL. So we'll go to the next slide. Here are just some examples of strategies that some systems have used, others have not. So one of the most common theme here is leveraging the electronic medical record. So there have been, almost all large health systems, almost all health systems are leveraging an electronic medical record. Some have more functionality than others. And oftentimes, electronic medical records can help workflows, and sometimes, based on either reasons for compliance or other sort of audit and feedback reasons, it can also maybe lead to slowing down of workflow based on the number of clicks and things that are out there. And so, many groups and many systems have leveraged the use of automated alerts to remind people when somebody's not at goal. This has been studied in a randomized fashion. That overall did not necessarily show in one particular study, single-centered, necessarily a change in control of LDL. However, amongst the people that actually use the EHR alerts, there was a difference in terms of lipid lowering intensification, hitting LDL goal, etc. So the thing with EHR alerts that are automated is you can choose to follow them or you don't. But what we do know is that amongst people that do follow them, there is a difference. And so I just want to keep that in mind that the story on EHR alerts may not be done, and they may just be another way to integrate these alerts to really help people meet this goal. And now you have this added element that wasn't there before in prior randomized trials or other studies looking at EHR results of actually having a quality metric to strive for, right? That wasn't there before. Before it was just, are you on a statin or not? Now, potentially, we'll have the opportunity to hit a quality metric. And so that may motivate people a little bit differently when it comes to reaching LDL goal. And maybe there might be some benefit of flags or OPAs, we call them in my health system, our practice advisories, or health maintenance tabs with their last LDL showing if one, when it was drawn, but two, is it under 70 or not in this context of a clinical ASCVD diagnosis. Next slide. Another resource that has been implemented is just looking at clinical workflows that are maybe institutional specific. So, for instance, is there some standardization when it comes to like order sets? Let's say an example would be if someone is being discharged from the hospital after an ST elevation MI. Is there some standardized workflow where they're placed on a high intensity statin, they have an LDL goal documented in their discharge paperwork, the patient has educational materials telling them what their specific LDL goal is, and there's a follow-up plan that when they get to their follow-up visit, which has already been scheduled before they leave, I'm making this up, I'm making up a workflow, but just giving you an example of like an idea. And that an LDL test, repeat test in 3 months is ordered to make sure that they get a repeat test to make sure they hit their LDL goal on the therapies they were started on inpatient, right? So just one example of like a workflow, like some standardization. Some clinical decision support tools at the time of medication refills is another thing that we've heard about, or some people are looking into, where hey, it's time for to refill their statin, but they're not at goal. Should we consider adding X or Y, right? Having some easier strategies in getting prior authorizations done for non-statin therapies, such as PCSK9 inhibitors or others, where you have an embedded process already, a workflow, if you will, or a decision tree kind of built into the EHR to help get these people these non-statin therapies. And then also looking at system level dashboards or other things people are looking at. And as Sarah mentioned, just lipid registries, understanding, based on, Outpace is a good example, just tracking data over time, like what's working for people, what's not, how do we iterate on that? So creating sort of workflows or systems of care, if you will, to help in an either automated fashion or a stepwise fashion, getting people to goal. Next slide. And then another thing that we're seeing a lot of is team-based support. So this is asynchronous care models, if you will. So remote monitoring, having, let's say, a clinical pharmacist or an APP that is dedicated only to lowering lipid. Now, you got to keep in mind, some of these things take resources, right? Resources that a system may not necessarily have. But if you have the motivation to hit a quality measure, it may sort of change the focus, or that may be another resource or reason to invest in resources to hit this measure. And so asynchronous care models, there's been some data to show that they actually help. There's data around lipid monitoring using pharmacists, or as well as support from care navigators, if you will, where lipids are addressed in between patient visits. So a patient doesn't have to wait, 6 months, a year, or even a year and a half to see you before their repeat lipid panel and an adjustment is made to their lipid lowering therapy. This could even happen without necessarily an in-person visit, through telehealth or other ways, to make sure things are happening so that their lipids are controlled before they come and see you. I think all clinicians on the call know, in this day and age, seeing a follow-up isn't as easy as it used to be. We're all stretched very thin in terms of bandwidth. And so another important thing to keep in mind is that we need to leverage teams to help, because if we leave it all in the hands of the providers, I don't think anything may change if we look at the track record of the last 20 years, in terms of achieving LDL goal. And so having a quality measure to go by may really start changing things on the resources that we utilize, on the systems that we develop, on how we leverage our EHR to hit people's LDL goals. And also the new guidelines, the 2026 guidelines, really confirm and emphasize a lot of these concepts. The new guidelines, as I mentioned, many of these patients we need to hit under 55. Lower we go, the better, right? And so you now have a lot of support through quality measures and updated guidelines in really promoting optimal LDL-C care. And I think that was my last slide. Next slide. We'll go to question and answers now, I believe, in the last 15 minutes or so of this session. So thank you all so much.
Thank you so much, Sarah and Dr. Shah, for that presentation. We've got a couple of questions in the chat, so I'll direct them as best I can. So the first question, I'm going to pass this one to Sarah. Will these expanded metrics for LDL apply to stroke measures as well?
Yeah, thank you for that question. So the association has incorporated this measure into the Outpace CVD registry. Stroke measures are updated to align with guidelines, and we do have separate LDL measures that exist in that module. We're definitely going to explore opportunities to harmonize this concept across modules, but for the purposes of today's call, we're focused on the Outpace CVD registry.
Thanks, Sarah. Dr. Shah, this next one is for you. Do you know if there have been any evidence of LDL improvement with GLP-1s?
No, that's a good question, and thank you for asking that. When you look at all the trials of GLP-1 receptor agonist or GLP-1 receptor agonist with combination GIPs, there is a lipid lowering effect. Now, is that correlated with the weight loss people are getting? Because we know that with weight loss, you do improve your lipids along with other things. But there's definitely improvement in LDL with GLP-1s. And there's also quite a cardiovascular benefit across the board with GLP-1s as well. And so I would say yes. whether there's a direct mechanism or not, that needs to be studied, but it seems to be correlated with weight loss for sure.
Thank you. All right. Let's see here. We have a couple of questions that I think I may answer as the programs director. So one of them is how will AHA promote the new LDL-C measure once it's added into quality reporting programs, which I think is an important question. So a lot of the times, and certainly what we hope to do for this LDL-C webinar is the incorporation of these measures into what are called our core programs. So we have a suite in the inpatient side, it's all of the Get With the Guidelines programs. On the outpatient side, those are our outpatient CVD programs. And so we like to incorporate these measures into existing programs to align those to the current MIPS measures, and then help to build resources and education like this one today and support around the adoption of those measures. So certainly on our vision board for 2027. So thank you for that question. This next one, I'm going to lob to Dr. Shah. We've got, what is the latest guidelines for patients without cardiac disease and otherwise healthy, but have an LDL-C above 130? So a little bit more in the guideline space here.
Yeah, absolutely. Great question. And that patient might very well be at higher risk than we think, right? We know that they don't have established atherosclerotic cardiovascular disease as of now, but that's where things like using the Prevent ASCVD risk score can be very helpful to understand, okay, what is their not only short-term risk or 10-year risk, but also what is their lifetime risk. This is where looking at risk enhancers may be very helpful because now with the 2026 guidelines, there's actually LDL goals for people based on their calcium score, based on incidental calcification seen on a CT scan they may have gotten for another reason, based on an LP little a level, based on premature family history, other autoimmune diseases, and so forth. And so the guidelines actually support moving all patients' LDL without any ASCVD, let's say, to under 100. And so that patient just alone has elevated LDL. And then to determine how aggressive you need to be to get them to under 100 or how you want to get them to under 100, that's where some of these risk enhancers play a role. And so this is the perfect patient to look for subclinical ASCVD, either through a calcium score or other biomarkers that increase their risk for that.
Wonderful, thank you. This next question is a little bit more operational. Again, I'm happy to take this one. So talking about this measure and Get With the Guidelines, I think a little bit more. So would a separate lipid registry be included to current registries, or would this be an additional chargeable layer and Get With the Guidelines? I don't envision this being a separate lipid registry at all. I think the incorporation of this measure, we can look at the individual modules and see if this can be an additional measure to collect a report. But I don't see this being a completely separate registry from its own. Of course, we want to see LDL as that modifiable risk factor. So that is the end of our open questions. If anybody has any additional questions, please feel free to drop them in the chat. But Dr. Shah, I do want to use the last minute or two of our Q&A to ask you, as a preventive cardiologist who, has these patients in your patient panel day in and day out, looking at those implementation strategies, maybe what's one pearl or one thing that you have seen particularly successful at Duke that you would like to impart on our audience?
Yeah, no, thanks for that question. One of the things that we've seen a lot of success in is these asynchronous care models. Using our teams, right? Using our clinical pharmacists, using APPs, using even our nurses to really not only help educate people on what their specific LDL goal is, but also putting in the motions of adjusting their medicines in between patient visits to make sure that their LDL goal is met. And so when you adjust medicines, it's also important to remember to throw in another lipid panel when you make an adjustment, because you got to see the effect of the adjustment that you made. And I think that part sometimes gets missed. And that's supported by the guidelines. And hopefully with this quality measure, that looks at both not only the lipid testing, but also the LDL goal will hopefully help with that. One of the things that we're also trying to do now in this world of AI is to leverage resources that are AI resources that are embedded within the EMR to make some of these workflows easier. And so I think not only my health system is doing that, but several others. And it's pretty exciting with what AI can do and how we can leverage it to help us achieve our goals.
Well, thank you. And one final question here for Sarah. If CMS chooses to incorporate this measure, would you recommend de-emphasizing the statin adherence measure?
Yeah, thanks for that question. So CMS will make the determination about the measures in their portfolio. From the perspective of the association, we can only support our concept and its value for our patient population.
Great. Thank you very much. Okie dokie. So if we want to move, we just have a couple of next steps for our wrap up here. Thank you very much, Angela. Okay, so as Sarah discussed earlier today, the LDL-C monitoring and management measure will be updated in the Outpace CBD registry. If you'd like to learn more about the Outpace CBD programs, please contact us at bit.ly/AQ contact us. If you have more specific questions about the Quality Payment Program or MIPS, you can contact CMS directly at qpp@cms.hhs.gov. And with that, I believe one more slide. Thank you very much. All right. Well, I want to say thank you all so much to our audience today for joining us for this wonderful webinar. We hope you have a wonderful rest of your Monday. Thank you all so very much.